So why don't we look at that in two positions, one in an upright position and two recreate it in a sitting position. So we can assess internal rotation, paying attention to the pelvis and assessing is there an internal rotation at the hip, just at the femur itself, fix the pelvis to approximate the tissue. We can change the angulation of that, winding the tissue up into an more adductive position. So we can assess the TFL component, is there an iliotibial band, or tensor fasciolateral restrictions here. And then we can also look at that same mobility and abduction as well, to see if there's a restriction in abduction. So too much here. Definitely we're getting more tissue here, tissue approximation. So let's see what happens in flexion in the same side. So let's see, does she have equal limitation and internal rotation? So yep, as soon as we go to internal rotation, yep. So you said how we should look at, you would want to look at compression or distraction. Maybe see if that makes a difference for the capsule at the hip.
Versus muscular.
Yep, yep. And what conditions, what type of population would you be suspicious of compression or distraction problems?
Not so much a problem, but seeing how it affects the range of motion, to tease somewhat great separation between a true joint issue versus perhaps a musculotendinous issue.
Yeah, in runners, maybe in runners, definitely in runners would be a good assessment tool to look at to help clear this up, to work on prior flexibility, on prior load training, to see, one, if she can, does it tolerate compression and loading, so we can load her in different positions to see if there's tissue reactivity or increase or decrease range of motion. And then from there we can clinically read and build a training.